We are live.
Okay. So very good evening. And today's in this Nuveka clinical conversation, today with us, the senior most doctor from Bhubaneswar. So I just want to welcome sir, from Utkal Hospital. This is senior most medical oncologist from that era. So very welcome sir from this Nuveka clinical conversation. Warm welcome on behalf of BR Oncology. So the first session and the session with you is breaking barriers in MHSPC tablet with darolutamide. Welcome, sir.
So thanks Arnav, and thanks to the Bayer team, and thanks for giving me invitation for speaking about the Aranaut trial. The topic of conversation today: the breaking barriers in metastatic hormone-sensitive prostate cancer doublets. Darolutamide plus ADT leads the way with Aranaut. So these are my disclosures, and so come to the topic proper. So, if you'll ask me one question, that what are the percentage of patient we see daily in the clinical practice, those who are metastatic hormonal sensitive? So almost 20% of patients, 20 to 30% of patients in in uh, in India, what we see in the clinical practice are metastatic hormone sensitive prostate cancer. That is the larger database what I told. But as we are more biased, as the prostate cancers are more biased towards the urologist, probably hormone sensitive prostate cancer patient we see comparatively less than that of uh, the resistant hormone resistant variety. So still around 20 to 25% we see the metastatic hormone sensitive prostate cancer. And the dynamics of presentation in the hospital, in the terms of the corporate hospital vis-a-vis the government hospital vis-a-vis the medical colleges also differs. So, so despite, and we know that we had doublets, then in between we go to the concept of the triplets. So if you go by the metastatic hormone sensitive prostate cancer treatment paradigm, then the Chartered and the Stampede C is the first trial giving the docetaxel plus ADT. Then the concept came to the hormone along with the ADT, abiraterone with ADT, abiraterone by the Latitude trial and Stampede arm G. Then apalutamide plus ADT is his Titan trial. Then the Archies and the Enzamet. The Archies also speaks about the enzalutamide plus ADT. Enzamet speaks about the docetaxel plus and minus along with enzalutamide plus ADT. Then comes the questions of the piece one and the RSN. The piece one and RSN speaks about darolutamide plus ADT plus dose is the triplet, is it? And the piece one also the ADT plus and minus docetaxel along with the abiraterone. Then the concept come of the ARA note, and which is about again comes the concept about the doublet, so darolutamide plus ADT. So we came from the docetaxel plus ADT to the hormone plus ADT to the hormone plus docetaxel plus ADT, and now again we are going to the concept of the darolutamide plus ADT. So again the hormone plus ADT. Okay. So, so it is an unmet need, remains of an efficacious treatment that offers the differentiated and improved safety profile for patients with metastatic hormone-sensitive prostate cancer without adding significant toxicity. And the RSN, as I already told, combination with the docetaxel showed the benefit and safety, which leads to approval in India 2023. So, so the aeronaut speaks about the Daru along with the ADT provides efficacy and favorable safety profile. And with Arnaud data, darolutamide has the potential to change the treatment paradigm, as now it would be the only the androgen receptor inhibitor which could be used with or without chemotherapy. So come to the study design. So it's a randomized double-blind placebo-controlled phase 3 study. The patients are of metastatic hormone-sensitive prostate cancer, histologically or cytologically confirmed adenocarcinoma with a good performance status. They have given the randomization of 2 is to 1, darolutamide 600 BD plus ADT versus the placebo plus ADT. And the stratification factors are visceral mets, present or absent, prior local therapy, yes or no. And the primary endpoint was the progression-free survival, uh, and uh, and the secondary endpoints are overall survival, time to initiation of subsequent therapy, the time to CRPC, time to PSA progression, the rate of undetectable PSA, that is zero point 0.2, time to pain progression, and also safety profile. So, and the open label phase until the final analysis, where there is 100% crossover to the open label dilutamide, and the selected endpoint was the OS, overall survival, and safety. So, looking into the patient profile, so Asian subcontinent people have been included, which is about 32%. And there are the people who included in the 0 to 2 PS. Gleason score more than 8 at diagnosis are in the range of 65 to 69%. The serum PSA, baseline serum PSA level was 21. De novo was 71% and the recurrent was 22%. Disease volume high as per the chartered criteria. The presence of visceral metastasis, endoderm more than 4 bone mates with one beyond the vertebral bodies and pelvis. So this is as per the chartered criteria. So that is in 71. The high volume is 70%, almost 70%. The low volume was 29%. Visceral metastasis uh, was 11 to 12%, and the bone only is around the range of 87 to 88. And many people, around 17-18% patients has got prior local therapy, 82% did not offer to. So, looking into the various trial, the Everotron trial, the Aranaut and the Embark and the Vision trial, if you look into the area specificness in the darolutamide trial, it is good to see that in India, almost 13% patients, India represent amongst the whole APAC region representation. So we have a significant amount of people, those who are actually represent our populations, and the patient subset what we see is actually the patient subset what we see daily in the clinical practice. So coming to the progression-free survival, the radiological progression-free survival. So the if you look into the radiological progression-free survival after a follow-up period of 25 months, the darolutamide plus ADT median has not reached. The placebo plus ADT, the value was 25 months. The 24-month analysis, it is 70 versus 52%, and the hazard was 0.54, and the p-value is significant. So coming to the subgroup analysis, first subgroup analysis, whether it is less than, so overall population, it is favors towards darolutamide. Whether the patients are in the major subgroup analysis, whether it is less than 75, 75 to, sorry, 65, 65 to 75, 75 to 85, more than 85. So across all group, whether the median PSA value is low or the median PSA value is less, ECOG performance status less 0 and more than 1, the Gleason score less than 8, more than 8, the high disease volume and the low disease volume, the various geographical area, the presence of visceral and the non-visceral means bone-only disease, and the prior local therapy, whether you have given or not given, all favors towards the towards darolutamide. So darolutamide plus ADT demonstrate a benefit across all the secondary endpoint in terms of the favoring towards the overall survival. The time to CRPC is significant. with an hazard of 0.4 0.4. The time to PSA progression is also significant, and time to initiation of subsequent systemic anti-cancer therapy, which is also significant, and time to pain progression is also significant. So, and the stratified hazard has been mentioned in the way. So, at the time of the primary analysis, the OS data was immature because there was 100% crossover. Since the OS was immature, the patient will be followed for the survival, and all remaining protocol placebo patients offered crossover worldwide after the primary prophylaxis, what already I have mentioned. So coming to the point one by one, so time to CRPC in the dolutegravir placidity, the median is not reached versus the placebo placidity, the median is 13.8 and hazard is 0.4. The time to pain progression, it is darolutamide arm, it is not reached. The placebo arm, it is 29.9 months, with hazard is 0.72. So a delay in time to pain progression can be of very high importance to patients who have not been demonstrated with other the AR inhibitors to date. The PSA declinement, or if I'll say the profound PSA response or the deep PSA response, which they have taken into 0.2 nanogram per ml at any time during the treatment in the overall populations versus those who are the percentage of patient in the in the placebo arm. So there is a three-time difference, 60 versus the 20%, and time to PSA progression, the median is not reached in the Daru arm versus the placebo arm, it is 16.8. So 63% of patients in the darolutamide doublet attained a PSA less than 0.2, and this represented a 69% improvement in time to PSA progression in the darolutamide versus the ADT. So coming to the proportions of patient achieved undetectable PSA with the darolutamide versus placebo in both high and low volume subset. In the in the high volume and the low volume subset, the PSA less than 0.2 in 6 month, in 4 month, 6 month, then 8 month, then 48 weeks, means almost the time of 1 year. And at any point of time, this number is quite significant. So any point of time, the basic decrement is around 54% versus 15.5%. And so also in the low volume disease, it is 82 versus 25.4. So in this subset also, it is quite significant that higher proportions of patients achieve an undetectable PSA of less than 0.2. So subsequent life prolonging anti-cancer therapy. So the patient's subsequent life prolonging anti-cancer therapy in the darolutamide arm is 32 versus in the placebo it is 42%. And the most common the anti-cancer agent they have used is docetaxel, and somehow later on it could be abiraterone and enzalutamide, and minor patients apalutamide, cabazitaxel is very less. Olaparib utility is also quite low. The incidence of the adverse effect is similar between the group. If you look into any adverse effect, is 91 versus 90. Grade 3 and 4 adverse effect is 30 versus 30. There is no difference. And serious adverse event is also no difference. The treatment leading to permanent discontinuations is also less than the placebo. So the median treatment durations was 24 months in the darolutamide versus 17.3 months in the placebo. And safety was independent of the PSA responses and consistent with the favorable tolerability seen both in the first in the Aramis and the Aracin trial. The rates of the common adverse event were low and similar between the two arms. If we look into the anemia, it is 20% versus 17%. Arthralgia is 12 versus 11. UTI also the in the Daru it is 11 versus 7.7. The back pain 9.7, 10.4. Increased AST almost similar. The hot flushes the 7.2. So in the placebo versus it is 9.2. The pain in the extremity is equal. The hypertension percentage is almost same. The bone pain percentage in the placebo arm is more than that of the darolutamide arm. The increased weight, little bit of increased weight that is happening in the darolutamide is okay. It's around in the 7.4 versus 7.7, and the fatigue was also not so more as you anticipate. So which is an expected complication, hyperglycemia It's a little bit more, 3.6 versus 6. That's just numerically a little bit more. The rest of the part is okay. There is no increment in the toxicity. The rates of adverse effect commonly associated with the androgen receptor inhibitors were similar across the treatment arm. If we look into the hypertension, the vasodilators, and flushing, hardly there is 2% or 1.5% difference. The hyperglycemia and the cardiac arrhythmia percentage, it is comparatively very safe. 6.8 to 8 to 8.8. The one of the major problem was also the seizure, neurological complications, the mental impairment, which is 0.5 to 1.6, and which is also not there. The incidence of fall is also not more. This is zero point 0.9 to 1.3. So and the mood issue was also practically it is less, and the dilutamide arm it is zero point 0.4 versus that's 0.9. So, so the event that are associated with the androgen receptor inhibitors also, and the number is less. And darolutamide extends this DASCO 25, it confirms the positive impact on the health related quality of life, extend the median time to deterioration by the factory total score by 5.11 versus placebo. And darolutamide is the first and only androgen receptor inhibitor to demonstrate the clinically meaningful delay in pain progressions and overall well-beings. And the time to deterioration in the darolutamide placidity is 16.6 versus the 11.5 month with hazard of 0.76. So darolutamide doublet therapy demonstrates a clinically meaningful delay in the deteriorations of overall well-being, especially on social, functionals, and the urinary symptoms domain, and that is how it has been depicted by the factory subscale score analysis. So to conclude, darolutamide plus ADT significantly improved the radiological progression of survival in patients with metastatic hormone-sensitive prostate cancer. It showed a benefit across all secondary endpoints. Darolutamide associated the deeper PSA response regardless of the baseline PSA, and is the first and only androgen receptor inhibitor to demonstrate meaningful delay in the pain progression, overall well-being, including social and family, functional well-being, and urinary symptom, and it has very favorable toxicity or safety profile. So darolutamide plus ADT without docetaxel will become an additional standard of care in metastatic hormone-sensitive prostate cancer, both in the low volume and also in the high volume subgroup. So thank you very much, and thank you for interaction. Any questions? We are ready to take.
Thank you, sir. Thank you for your nice presentation, sir. And if there are any kind of any query from audience to sir, so just we can stay for 1 minute, or otherwise we can conclude the session just
Sure,
for
sure,
1 minute.
sure. Okay.
So I think not there is no such kind of question. So with your permission, we can go for concluding the
We
session.
can go. Yeah, yeah, we can go.
Thank you. Thank you very much, sir. Thanks for your presentation, sir.
Thanks. Thank you. Thank you very much.
Thank you.
Bye bye.
Yeah, good night, sir.
Good night to you all.
So technical team, and we can conclude the session.
Okay, sir. Thank you.
Thank you. Thank you.